Good afternoon, and welcome to Securing the Ever-Expanding Healthcare Enterprise Through Identity Governance, a Health System CIO Media Inc. production sponsored by Imprivata. Just a little housekeeping before we get started. My name is Anthony Goriah. I'm the Editor-in-Chief of Health System CIO, and I will be your moderator today. We are looking forward to some audience participation. We have your questions and comments box, which you can use at any time to send those in, and we'll take those later in the program. We're also going to do a little poll, so please keep an eye out for that. Nice view today. If you want to click on the top of your screen, the center there, get it in side-by-side mode, then you can adjust the divider to make the slides as big as you like, and make sure it says speaker view in the top right-hand corner. Just so you see how we're going to spend our time today, we're going to do about 40 minutes with our panel discussion featuring Steve Goriah, VP of IT, CIO, and CISO at Westchester Medical Center, Phil Curran, VP, CISO, CPO at Cooper University Healthcare, and Wes Wright, CTO with Imprivata. So let's jump right in and to our conversation. Can we get an overview of your organization and role? Let's start with you, Phil.
My name is Phil Curran. I work at Cooper University Hospital. It is a level 1 trauma center in South Jersey, located right across from Philadelphia. We manage the 7 southern counties in South Jersey, so we have the biggest footprint for a level 1 trauma center in South Jersey. We also have about 150 ambulatory offices located in South Jersey and in Pennsylvania.
All right, very good, Phil. Thank you. Steve, you want to give us a little bit of information about your organization and your role?
Great. Thank you, Anthony. Glad to be here, everyone. Good afternoon. My name is Stephen Goriah. I'm the CIO and CISO of WMC Health, located in Hudson Valley, New York. We're a 10-hospital system spread across the Hudson Valley. We have about 150, 200 ambulatory care practices as well. Looking forward to a really robust discussion with the team. Thank you.
Very good, Steve. Thank you. Wes?
Hi, my name is Wes Wright. I'm the Chief Technology Officer at Imprivata. I feel a little inadequate. Both Phil and Steve both have a couple of different titles. I mean, Steve's the CIO and the CISO, and Phil's the CISO, and I guess CPO's Chief Privacy Officer, I'd imagine.
Yep.
And I'm just the lowly CTO. Been at Imprivata a little over 2 years now. Prior to that, I was CTO out at Sutter Health, and then a couple of other locations. Actually been on the provider side of the healthcare game for the last 25-ish years, and this is my first venture over into the vendor side. And I think couldn't have gone to a better company. Imprivata, you know, we're known and yeah, okay, I'll push it. Known and loved throughout the healthcare systems. Known for our tap and go, but now you know, with our purchase of Paradigm 2 or 3 years ago, we just built out what we think, along with our Microsoft partnerships, probably the most comprehensive suite of identity and access management tools available out there.
So,
all right.
Wes, if you feel better, I'm giving up the CISO title very soon as well. So
okay, so you'll be a single title guy too. It's a pretty easy world to live in.
I mean, is the goal to get multiple titles or to get rid of those multiple titles?
Well, you know,
be as efficient as you can.
Yep. I think if one title is good. I think that's. But if you start collecting them, man, that's more job security, Anthony.
That's true. All right. So we'll talk more about that later, maybe.
Okay.
Perhaps. All right. Very good. Let's talk a little bit about the impact COVID had, just sort of as a background thing, I think, to describe where everyone is. a little bit about the impact COVID has had on your organization and your community. Phil?
It has had a huge impact on our community and the hospital. Camden is a city. It is a low-income city. If you have read anything about COVID, you would know that the low-income individuals have been more adversely affected with COVID than other types of population. About half of our COVID patients have been from the city of Camden. The other half have been from, within a 10 square mile of Camden City. The hospital has been affected. We've had to open up, not open up, but transition rooms to ICU rooms on an overnight basis. Of course, our dollars have been affected as well, because we haven't been able to do any of our what we would call our high money making procedures like ortho, neuro. We're looking to see how that's going to affect us for the rest of the year and going into 2021. We are still seeing COVID patients, not as many, thank God, but we're beginning to get a little bit back to normal.
Mm-hmm. Yep, very good. Wes?
On the other side of the fence, of course, because it did affect organizations like Steve and Phil's, it had to affect us. There's everybody, for the term I like to use is, everybody's keeping their powder dry. They don't really want to commit to big projects, commit to any projects, because of COVID. They don't know which direction they'll have to turn. Like Phil was saying, they're having to rebudget. Everybody, stopped any kind of non-emergent care, and so they just, not that there was anything they could do about it, but just created a great big budget hole. And so if you're selling into a healthcare delivery organization, that kind of ground everything to a halt. Fortunately, we have a pretty infrastructure type of product that actually increases the efficiency of the clinician and being able to see the patient. So we didn't take a big dip like, say, the airlines industry or something like that. So there's that. And then just like everybody else, we had to close all of our offices. We have offices in the UK, Australia, and of course here in the States, and everybody is now working from home. So we've had to adapt to, how do you do engineering collaboration using Zoom? And if anybody's got a good whiteboard application out there, we've tried a bunch of them, and none of them really seem to be working that well. And then something that's really cool, and we might get to it later, is our customer input. Our customers out there that have been longtime Imprivata users did come up with and shared with our community about 30 or so different ways that they're using out-of-the-box thinking, that they're using the Imprivata products to help deal with the COVID crisis and response. And that was really super cool to see how our customers use the product in different ways, and how willing, and I think this is about healthcare though, how willing they are to share those different methodologies and using the product. It's pretty cool.
All right, great, Wes. Steve, you want to talk about the impact at your organization?
Oh yeah, it was a tremendous experience for me and my team. I think we lost the video, but that's quite all right. We're back to somewhat normalcy right now, but during the height of the COVID crisis, we were running 24/7. At some point, I forgot what day it was. We transformed the healthcare organization, we created about 70% more beds. We opened testing tents at each of our 10 facilities, from COVID testing to antibody testing to, we rolled out about $3 million worth of new technology to really monitor patients in a room, monitor the COVID patients, really transform the organization and do everything like it was an urgent need. So my team really came through with flying colors. We deployed, we delivered, we were the glue that held it all together. We deployed some amazing new technology. For example, we got about 5,000 to 7,000 users working remotely within a week using Citrix and partnering Citrix and Cisco. That was an amazing experience. We really got the temperature scanning, working with CARE.ai and other organizations to really bring the temperature scanning to the forefront of all our entrances. We really went through a lot, and the team came through, and technology really was a shining star. I understand if the caregivers, you cannot even come close to that, but technology was the driver that really reacted. We reacted, and we reacted well, we reacted fast. But it was a life-changing experience to see what you can do when you're called upon to do everything now and do it well. So I think it's going to change what we do going forward, specifically related to security, but also the delivery of care. How do you reimagine the ambulatory care? How do you reimagine telehealth? How do you reimagine home visit? How do you reimagine the new world of home monitoring? How do you really care for patients? How do you regain the trust of patients that were even afraid of coming to the hospital before? How do you get them back in here? Or do you really change the care delivery model to focus on the consumerism of healthcare? And how do you keep that secure? So there's so much that happened, so much that's changing, and technology is going to be at the forefront of this. So as a technology leader, as CIO, we're positioned appropriately, but we have to really partner with the organization's financial and clinical leaderships to really drive the change that's upon us.
Yeah, Steve, one of the, you mentioned it, and one of the things we've heard from other CIOs and executives is we were surprised at what we were capable of doing. Almost the speed with which we were able to do things was surprising and pleasantly surprising. And I would imagine IT departments have a different feeling about themselves and their capabilities than they may have had before this. And there's a different expectation that's been set in terms of how fast things can be accomplished. And I would imagine there's no interest in going back to the old slow pace of how things used to get done or not get done. Is that accurate?
Absolutely. I was personally stunned. My team, we deployed stuff so fast and did it so well that it's changing the expectations of our leadership and the clinicians. But again, you did things, you did not, follow all the protocols, and maybe quality suffered a little bit. You have to admit, when you're doing things fast, you're not, systematically approaching anything. You're not applying the appropriate governance. You're making decisions on the fly. There's some things that can be improved, but the level and speed of care and the level and speed of what we delivered, absolutely, the expectation has been raised, and we have to really adapt to it. But we cannot continue just to do things reactionary. I got to go back to some level of strategic thinking and strategic application of technology. But again, you have to be able to do both at the same time and be able to deliver the technology to the clinicians and be able to deliver them in an expedient manner. Yeah, absolutely. It's been an eye-opening experience.
And I
Phil,
think,
go ahead, Wes.
Yeah, I think that this taught us what what the software industry and folks have always known. It's the thought of MVP, that minimum viable product. Like Stephen was saying, it didn't go through all the rigor and testing, and it didn't get to it didn't answer 90%, all the way up to 90% of the problem. But you know what? It solved 60% of it, and 60% was better than the 0 and the other month it would have taken to get to the 90%. So one, I think it taught us the value of a minimum viable product, and two, focus. When you focus, like I'm sure Steve and Phil's teams they had one focus, and that was to support the caregiver in them dealing with the COVID crisis. And unfortunately, what I'm hearing now from some of the folks that I talk to, my old peers, they're going, okay, like Phil was saying, things are starting to tail off a little bit. The crisis is, we're not getting inundated, and now everybody's piling back on. That plate that used to just be full of COVID, and everybody was talking about, let's get this COVID done. Now everybody's starting to pile other stuff back on that plate to where you kind of, that focus, you're losing a little bit of that focus that is really what enabled people to move quickly, I think.
Mm-hmm. Phil, I'd love your thoughts. Anywhere you want to jump in on all
that? I agree with Steve. Our ability to get things done was, from my perspective, was just amazing. We deployed technologies to monitor patients within the rooms, so the nurses and the doctors did not have to go into the rooms to save our PPE. Mm-hmm. We deployed technologies where loved ones could talk with their with the people that were in the hospital. We deployed technologies that would allow us to do the remote access, to do the to do the telemed. We already had processes in place, but it was just, we got rid of. We had 7,500 employees just start working remotely within 2 weeks. We had telemedicine up within 3 days. So it was just amazing. Just amazing.
Phil, what about that balance? So we talked about the things that have to be sacrificed to speed. When speed is the objective in an emergency situation, there are certain things which Steve mentioned around governance that have to be sacrificed to a certain degree. Number one, is that accurate as you see it in terms of how things went? And so if we're bringing all that back, do we want to bring it all back? Or do we want to just bring some of it back? Do we want to totally go back to what it was? Or do we realize that, hey, to what Wes was saying about the MVP, is there somewhere short of going all the way back that we want to be so we can move with speed?
There is no going back. I can't speak for anybody else, but our senior executives have seen what we can do. Fortunately, from a governance standpoint, I'm a member of Cooper's incident management team. So I was in all of the decision-making processes. So they would never forget to come and talk to me. Phil, what do you think about this? What's the best way to get this done? Is there a way that we can make this effective for the patient while keeping the privacy and the security of the data? So that really wasn't an issue for Cooper. Talking to my peers in other hospitals around South Jersey, the answer is yeah, they were just left out of the loop. But we can never go back. We'll never go back to the old plodding ways to get things done. And quite frankly, I'm seeing that now. How are we going to deploy telemedicine permanently? How are we going to deploy people working remotely permanently? So,
right.
Going back.
As a healthcare leader, you have to be a chameleon these days. You have to be adaptable, right? What Darwin says, not the smartest will survive. The ones that are ability to adapt to the changing environment will survive. So you have to be able to adapt and apply. I think what's going to come into play is applying lean principles to everything you do. Trying to be lean, trying to be nimble, but still have certain governance controls and processes and your PMO, but you've got to really be able to do streamline operations and streamline delivery, streamline governance. So applying lean principles to the new world, I think, is where we got to go as a technology leader. But yeah, there's no going back, but we cannot do what we did. We're going to fail. Something's going to go wrong, but you got to make sure that you're not going back to the old ways of removing that cog from the wheel and applying new technology, new processes, and really reimagine as technology leaders, how can we deliver efficiently, but deliver things that are quality-based and things that are safe for our patients. At the end of the day, we're here to treat the patient, and one little mistake that you make can really significantly affect the patient. One security rule, regulations, or anything that's really not appropriate, allow too much access or not allow someone with inappropriate access can detrimentally affect the patient. So as you work to re-engage the patient and regain that trust, you have to walk that fine line of being able to deliver on time, being able to be nimble, but you still have to be able to do the right thing and make sure there is appropriate controls in place to deliver it.
Yeah.
Well said.
Anthony,
Go ahead.
Anthony, I don't know if you noticed or not, but I changed the background, and I'm going to step out of the way. So this is what we're talking about, really, is that minimum. Oh, you can still see the cloud. There we go. That minimum viable product. You know, that down there on the bottom, the physician comes to you. I need to get from here to there, and I need to do it faster. Well, you give them a skateboard, and then you give them a bicycle, and the whole time that you're iterating, they're happy, and to them that's speed. But what we used to do is that top line, which is, okay, well, I need to get you from point A to point B, so I need to build you a car. So you come back to me in 18 months, I'll show you what I got. And they're ticked off the whole time. So I think we're down on that bottom. I think we're, like Phil was saying, we're firmly ensconced down on that bottom methodology that I don't think we're going to go back up to that. Give me 18 months so I can plan it and build it again. So,
very good. Excellent. Excellent. I like the visuals being brought in. Very good. You know, Phil, you had mentioned that you were at the table, so you were able to make sure that nothing was rolled out that had any security vulnerabilities. I don't know. I wonder if others, you know, didn't quite have it set up that way, or if you or Steve or anybody did things that you took risk knowing what you were doing, but maybe risk you would not have taken in a non-emergency environment. So let's talk a little bit about that. Phil, you want to start?
Well, you're always going to take more risk in an emergency environment because the bottom line, like Steve said, is that we have to treat the patient. Okay, but part of treating the patient is not just the physical treating of the patient, it's also their mental health. So one of the risks that we had was, how are we going to allow the patient to communicate with their loved ones? They can't come into the hospital. We're not allowing visitors into the hospital. So how are we going to allow them to talk? Now, again, a lot of our patients are poor, so they don't have a cell phone or any way of doing that talking. So we went out and purchased 150 iPads, and we got another 50 donated to us. So we were able to give the patient the ability to do, the patient and their loved ones, the ability to do that FaceTime. For patients that we wanted to have them loved ones in the hospital, it was very, very rare, but we would allow the loved one to come up to the floor, stand outside of the room, and we would have a video conferencing, a mobile video conferencing suite outside the room where they could talk. Those sorts of things went in. How do we do the temperature monitoring? How do we make sure that our employees are safe when they're treating these patients? It's all about risk management and what your acceptable level of risk is, and that was well orchestrated at Cooper because, quite frankly, we've done this any number of times with SARS, et cetera. So we were well prepared to manage this situation.
Steve, as the CISO, are you deciding almost in real time the risk that you consider acceptable, or is that something that you need to explain to the CEO and the board and have them assume responsibility for the risks that you've laid out? But then, if you've got this emergency situation, do you have time for all that? Or do you have to make some decisions yourself? Talk about the CISO role and who decides the level of risk that's acceptable, and then how that might change in an emergency environment.
So that goes back to creating a culture of security where everyone is engaged and aware of what the parameters are. Of course, you have to make the call sometimes, and you have to really dive into these things and make the call. But if you have a culture of security where everyone thinks of security first, and it's been a long journey for us, and we've been on a high-trust journey and really focused on creating that culture of security across our organization, where the nursing staff, the clinicians, that everyone else is thinking of IT security. And it's amazing what has happened here over the past 3 years, where everyone is focused on security first. But when a pandemic hit, people are focused on the patient first. And it was a constant thing of engaging with my team on the ground and myself and really focusing on really delivering the care, but be aware of the security risk and what risk was acceptable to us, where security is really a risk management, a risk tolerance proposal to our organization. So yes, the end users and nurses, the clinician, my team, were fully aware that security comes first and security was all there. But there were times that I had to get involved and really change what the direction of the technology would be, or apply some other controls with the technology to make sure we were protected and we were safe. But it was a collaborative effort, mostly driven by us, but the clinicians and other operational leaders were a true partner in this as well.
Wes, any thoughts around that dynamic?
Yeah. We saw a couple of different things right at the beginning. As Steve and Phil said, that they immediately had to. I think Phil said he had 7,000 people that one day they were working in a building, the next day they went home. And what we saw was a lot of folks not having some kind of two-factor or multi-factor authentication for those remote workers, and not more than a week after the shelter-in-place stuff happened, we saw that in Imprivata and went, look, we can't. We're a health IT security company that focuses on identity, of course, but we don't have our customers or our non-customers having to do that. So we offered our remote access, multi-factor authentication, remote access licenses for free through July 31st. Really easy to stand up, and had quite a few folks, about 170 customers and non-customers take us up on that. So that's one area that we saw, and kind of one of those things that you normally wouldn't do if it weren't for a pandemic. Our self-service password reset software has always had the capability that if you turned it on in a reverse proxy method, you could let people reset their passwords from a remote location. Something that I'm sure just even talking about it now makes both Bill and Steve skin kind of crawl with the thought of that. But we were kind of victims of our own success. When they're on-prem, they're tapping into this and tapping into that and have no idea what their passwords are. And then all of a sudden they had to work from home, and the help desk were just getting killed with password reset requests. And so we said, look, there's this way you can use the self-service password reset in reverse proxy, and you can let them reset their passwords from home. And a lot of people did that. And I bet that's one that's going to be pulled back pretty quick too.
Very good. Well, I guess we'll see. We'll see. Phil, let me start with you with this question. When we're talking about the perimeter, when we get into more of the discussion about identity governance, and one of the ideas is that the ecosystem of healthcare just continues to grow, expand. There's been a lot of M&A in New Jersey. We know that. You're in the area. I'm in New Jersey. You had Hackensack Meridian, all that kind of stuff, and it's going on throughout the country. Do you think the perimeter of the healthcare organization, quote unquote, will continue to grow and morph? And what does that mean from a security point of view?
Yes, I believe that it will morph. I kind of look at it like, you're making scrambled eggs. and you're pouring the eggs into the pan, and that's the perimeter. It just keeps on expanding, and it's liquid. It's never. It'll only stop until it gets to the border of the pan, but it's never. It's never. There is really no, from my perspective, there really is no perimeter anymore.
Amen.
Docs want to look at X-rays on their smartphones. We've got we're an academic medical center, so we have medical students who want to do research from home. We've got residents who need to be on call all the time, so from wherever they are. So there is no perimeter anymore. We've got vendors, third-party risk management. We've got vendors. We had to bring in about 100 locum tenens nurses from all over the country. How are we going to get their ID set up? How do we make sure that they've got all their quals done? So really, from my perspective, there is no perimeter anymore.
Wes?
Well, Phil could have, being an identity company, about five, six years ago when I was working with Microsoft out at Sutter on a project out there, I started to hear the Microsoft people say, well, identity is the new perimeter, meaning that, it's identity is how you control things. And recently, Joy Chick, who's the corporate VP for identity at Microsoft, in a blog said, yeah, identity used to be the new perimeter, but now it's the new control plane. Because right at the center of all that stuff, the users and roles and the locations and the devices and the applications, the one thing that ties all that stuff together is that digital identity. And you have to be able to be assured that digital identity is who you think it is, one, but that's how you can control access to applications, data, and network resources. Because like Phil said, there is no perimeter anymore. Identity is that new perimeter as well as that new control plane. That's, Imprivata, that's Wes's opinion. And fortunately, it melds in there with Imprivata's opinion too.
Well, that works out well. Steve?
Yes.
I'm still thinking of Phil's fried egg and making me hungry.
I know, that was good.
I could see it too. I could see the eggs spreading across the pan.
I have a visual as well. I haven't had lunch yet, so that's even more. So I agree with Wes that, identity governance is key to this. And having a tool, the right tool that really links up and really manages the broad spectrum of users you have with different roles, and really enable us to identify who has access to what and make sure that's appropriate is the key to all of this. And in a tool like Paradigm, I think it's fantastic. I'm a big fan of it, and I think you guys are positioned appropriately and correctly in this time to really penetrate the ecosystem and really help organizations manage their identity governance, because I don't think many of us have a robust tool as Paradigm in place that will be able to help us to manage this. So,
Steve, I worked at four different locations, and I never had an automated identity governance system.
Yeah.
I made several failed attempts at standing them up, but the problem always is that one, it's plumbing, and nobody really cares about plumbing. You're not gonna make the physicians super happy. They're not gonna applaud you at the next MEC meeting because you stood up an identity governance system. And two, that just, man, it seemed like whenever you tried to stand one of those up, everybody, HR wanted to redo their job code so that everything would be automated. And now with the way we've got Imprivata identity governance working, that's, in 6 months we can get you up and running and provisioning into your EHR applications, Exchange Online, your ERP, and so on. So I appreciate the call out. I'm pretty proud of that product and where it's going and what we're doing with it. Thanks for mentioning it, Steve.
No, it's a great product.
Thanks.
Phil, do you think identity is the key here?
Yes. I do. It's the key to everything. I mean, who has access to what? Where can they access it from? That is the key. That's for me. That's the new. That's the IT security problem. Is identity management.
All right, that makes sense. That makes sense. Let's go with Steve. Let's go with you first. What do you see as the main security threats on the horizon?
If you asked me this question 3 months ago, it would have been a different answer. So with COVID and the changing technology, the rapid deployment of technology, things are changing so fast. My major concern is that there are people out there that are watching us. There are people out there that are trying to capitalize on the vulnerabilities that exist inadvertently or naturally, that as we move to more technology, the parameter keeps growing, there's no identity governance, there's not appropriate identity governance, there's not the right tools in place. And as the new normal becomes more and more prevalent, and we keep deploying technology to drive change and to meet the new consumer demands, security has to evolve. Security has to really focus on how do we protect our data, how do we protect our patient, how do we restore that trust. And organizations have to really invest more in security to drive the necessary changes needed to really meet the enhanced demand. So it's an evolving world, and security has to be, again, like a chameleon and adapt to it. So the new normal really does scare me.
Phil?
I completely agree with that. It's the speed of things that people are expecting now. They'll want the governance to keep up with that, and quite frankly, I don't think that our security people are ready for that. They're used to the old ways. They're used to the slow plodding way to get things done, but they need to be adaptable, and quite frankly, most of the people that I deal with, most of the security people that I deal with are not adaptable. They're not flexible. You've got to do it this way. Well, that's not acceptable anymore. So we need to be able to keep up, because if we don't keep up, then we're going to be left behind. And if we're left behind, we put the organization at risk.
So, Phil, are those, you talking about internal people in the health system on the IT team? Or are you talking about vendors? Or are you talking about in terms of not being adaptable?
I'm talking about people that I deal with at Cooper, mm-hmm. and people that I deal with outside of Cooper, vendors, etc. Okay, they need to be flexible. They need to, if I want a vendor to come on quickly, they need to be adaptable to make sure that they can meet those expectations. And there were times during this pandemic that we just said, sorry, you're just going way too slow. We got to get this done, and you can't do it. So it's both internal and external.
Wes, there's a lot there. So we've got our main question about the security threats on the horizon, yep. But the point Phil is making is extremely interesting, and I'd like Steve to weigh in on it after you do, which is there's a new environment here, and some of the people are not suited to function in this kind of environment. They're not flexible, they can't move quickly, and they just don't have it in them. So are we going to see turnover? Are we going to see those people are going to have to be, some people are going to have to be moved out, and new people are going to have to be moved in?
Yeah, I think so. And I'll go last to first on that. I completely agree with Phil. Some organizations, to some degree, we taught our vendors to go slow. I mean, we have to mea culpa some of that, because we weren't moving fast. The health delivery organizations, well, we had to move fast. We were forced to move fast. And now we're going to find out what vendors can make that pivot with us. And the ones that can't will be left to the side. At Imprivata, we used to come on site. Almost every install, we would come on site to help folks do the implementations. All the implementations and training that we're doing right now, it's all virtual. we had to make that pivot, and the vendors who can't make a pivot like that, yeah, they're going to be left in the completely in the dust. Now to the other question, what do you see as the main security threats? Well, I think ad infinitum, my main security vulnerability is going to be that end user and their education level around security. So it's the social engineering threats that I find the most threatening out there right now, especially as people are working remote and working from home, and they don't have that peer reinforcement, all the time, that constant reminder, the posters at work and that kind of stuff, and they'll start to get maybe a little lackadaisical on their security posture, and then the social folks will just be able to go in and trick them into doing things that they normally wouldn't do.
Steve, your thoughts around this? It's very interesting. Almost everyone got a test, right? When COVID was at its peak, your staff got tested on the individual level, right? Who can respond? Who can handle the crisis? Who can deal with it? And as Phil said, the vendors got tested. Can you do what I need you to do in the time I need you to do it? And it's almost like we mentioned evolution before. Who evolved quickly enough
Darwin.
to be, right? Who evolved fast enough, and people showed their colors and what they're capable of. So your thoughts around that?
So it's threefold here. First, you have to look at your vendors. Are they the right vendors for you? Are they adaptable? Are they nimble? Are they willing to work with you? Do they have capabilities? Do they have the culture within themselves, or the technical capacity within the organization to really react to your enhanced demands? Second, you have to look at the leaders. As a leader of the security team, leader of the IT organization, you got to be a change agent. You got to be able to drive change within your organization. You cannot rely among the people. People some may be adapt, some may not be able to adapt, and you got to make that change. But you have to be able to sell that change in culture, the change in environment, the change in the new normal on what's required. Things are always going to change. You have to be able to be that change agent and drive change throughout the organization. Third, you have to be able to find the right employees. And even before COVID, you have to have the employees that are willing to adapt and change and move. If you have someone that's not even coachable or willing to be motivated or change what they're doing, they're not the right person for you. So, and again, and it goes back to your organization as well. As someone says, culture eats strategy for breakfast, right? You have to be able to apply the strategy for your culture. I may have grand ideas. I may want to be the greatest change agent, and unless my culture and my organization is receptive to it, we're not going to get anywhere. So you have to tailor your approach based on your organization and your culture, but you, as a leader, have to drive that. You have to be able to be that change agent and really drive change across your organization, not just within your IT security silo or with your vendor. Throughout the organization, you have to bring change and be that change agent to be able to allow that change to permeate across the enterprise and bring to fruition what you really want to achieve with the clinicians and the operations leaders as well.
Very good. All right, we're going to do our little audience poll. Before I launch this poll, I want to figure out what a number is for significant increase. So we see the question, Steve. What would a number be, a percentage for a significant increase in a security budget?
I think security budgets are very minimal now, and it's hard.
What's that? No, I just want a number. I just want to get, what would I'm trying to define this question before we launch it. So what would a percentage be that you would define as significant in terms of an increase in budget?
I think a 50 to 75 increase in IT security budget is required right now. Security has been underfunding forever. And COVID, if you had asked me this question before COVID, I would have said 50%, but 50 to 75%, I think, increase security budget.
I'll go with that too.
Let's define it for this question. We're going to launch the poll now. We'll define it as 50%. When we say need to be significantly increased if looming threats are to be managed properly, we're talking about a 50% increase. So do you think that needs to happen, that essentially IT security budgets need a minimum 50% increase to handle things properly? Please answer that, and we will take a look at it in a moment. So while people are answering the poll, we're going to go to the Ask a Co-Panelist. Wes, I'm going to give you an opportunity to ask one or both of your co-panelists a question.
Yeah, this is a question for both Steve and Phil. So, you know, we were doing a bunch of virtual care telehealth visits. It's a two-parter. When do you think, or do you think, CMS will stop paying parity for those telehealth visits? You know, paying the same as if it was an in-person visit. And two, where do you think, you know, because some, you know, telehealth went up to like 70, 80% of visits at most organizations. Where do you think after CMS, or if you, from a parity perspective, where do you think your telehealth visits will end up as a percentage of your visits, say 6 months from now?
Phil, you want to go first?
Phil asked the question.
All right, so I'll take the second one first, which is the percentage of telehealth visits. I would say 30 to 35%, maybe a third of our visits would be telehealth. Quite frankly, our patients love it. Our patients love it. They don't have to leave the house. My wife, she's had all of her oncology visits through telehealth. She doesn't have to leave the house.
Right.
As for, what was the other question again?
When do you think CMS will stop paying the same price for a telehealth visit as they do an inpatient visit or an in-person visit?
I would say probably in the right around the fourth quarter, but they are getting a lot of pressure from everywhere not to keep it on parity. The Congress is doing it. All of the hospital associations are doing it. But I'm thinking fourth quarter.
Cool.
Steve?
All right, so I think it's a seismic shift in the way we do provide telehealth, and that's going to keep growing. I see us to 45–50% of our care being done via telehealth. It requires a bunch of different things. It requires partnership with community organizations. It requires partnership with others like CVS, Walmart, Walgreens. It does require us to really rethink the way care is delivered in the ambulatory setting. That's going to continue to enhance the ambulatory need. And even before COVID, the younger generation, no one wants to come to the hospital anymore. And I think that's going to be even more significant now. With CMS, I saw somewhere that Seema Varma said there's no going back. I saw just recently Chime just sent out a survey that says 80% of the CIOs are really focused on getting them to lobby Congress for enhanced reimbursements for telehealth and even in-home monitoring as well. So I think I cannot predict when it will go away. I think it's here to stay. And I think the government and CMS will keep that going in some form. And with the push of a New Jersey Hospital Association, Haney's, and places like Chime and HIMSS, I think the possibility or probability exists for it to keep it there for a long time. I think this is a seismic shift where there's no going back.
Gotcha.
All right, let's go to our poll. We have the results, and I call this, when Wes is involved, I call it Guess with Wes. So what do you got, Wes? What's your percentage agree?
Well, you know, Anthony, I think this is going to be the easiest question, or easiest poll question that we have ever done together, because this is going to be in the super, I would say 98%.
98%.
Yeah.
All right, Phil, where are you going, Phil? What do you got?
I'm going 100.
Oh, he's going 100. Wow, that's a man with conviction. Steve?
Yep.
I'm going to go Price is Right style, 96.
Yeah.
96. Well, the winner is going to be Steve at 92%. 92%.
Wow.
So 8% of the folks thinks you guys don't know what you're talking about. So
Yeah.
we'll have to figure out who that is. And
Well, we've got
probably the smartest of the bunch.
8% of the audience is CFOs, Anthony.
Yeah.
Nice one.
Very good. Very good. All right. Well, listen, that's about all we had time for today. Appreciate everyone coming. Regarding continuing education, the final slide in this deck can be used as a certificate that you attended. You'll receive an email when the on-demand recording of this event is ready. If you want to sponsor one of our upcoming events, reach out to Nancy Wilcox from our team, and you can go to our website to register for our upcoming events. With that, I want to very much thank our wonderful panel. We always have a good time. Steve Goriah, Phil Curran, Wes Wright, and I want to thank Imprivata for continuing to make these events possible and help the industry. And I want to thank you, our attendees, for coming. And with that, everybody have a wonderful day. Thank you.
Hey, thanks, Steve. Thanks, Phil.
Thanks, guys.
Appreciate it.